Dr. Tomer Singer, I am honored and privileged to have you with me here today. You are known as one of the leading experts in reproductive medicine. You have all the credentials. You're an MD, and you also have an MBA, and you're also the head of Northwell Fertility, and you've been a guest on 60 Minutes. So yes, having you here today is such a big deal, and I am so excited to have you discuss all these things with me today, all things fertility. Let's start with your story on what inspired you to do fertility medicine. I was really touched to hear that story, but please share it with our audience.
Sure. First of all, thank you so much for having me, Lisa. It's an honor to be here.
My pleasure.
So what got me into medicine in general was my father. He was quadriplegic. He was paralyzed from the neck down. He was injured during his time in the army, and he was shot. And essentially, all his life, adult life, since age 18 until he passed away at age 50, he was in a wheelchair, bound to a wheelchair. His left arm was amputated. His right arm was paralyzed given the height of the injury in his spine. And, growing up, that's all I knew. And my parents struggled with infertility because they could not have just a intimate relationship the way, most people do. And they had to go to 2 years of very challenging infertility treatment. And I was born in 1976, so that's preceding by 2 years the first IVF baby that was born in the UK. So I'm a result of IUI, what we call artificial intrauterine insemination. Mm-hmm. So my mom had to take injections, hormone injection, for 2 years. Same hormone injection that I'm prescribing on a daily basis now to my patients. And after 2 long years, they were successful. And that's kind of got me interested in medicine, and specifically in reproductive medicine, or reproductive endocrinology and infertility. So growing up, hearing the stories and knowing that I didn't have any siblings, and at some point they just had to give up the dream of having a larger family, I knew that this was something that I really want to focus my career. I went to medical school, 4 years of OB/GYN residency at Lenox Hill Hospital, 3 years of subspecialty it's called fellowship, clinical fellowship at Cornell. And then, from that point on, really the career was focusing on helping couples and women to achieve their dream, the same dream that my parents had when I was, became aware of that story.
It's such a beautiful, poignant story, and that's why you have such a special connection with all your patients. So I met you about a month ago at the Women's Health and Halacha conference in Woodmere, mm-hmm. and I have Orthodox clients, and at the intersection of women's health is fertility. So what was the catalyst for you to form a partnership with PUA?
So, a lot of the patients that live in New York have a religious observation or requirement that makes them unique in the sense that they need an approval from a rabbi when they're trying to do a fertility workup. Even something as simple as semen analysis is not as simple of telling a couple who are not religious, who are not Orthodox, because the rabbi needs to approve it. Because in the Bible it says that you should not be masturbating, you should not be having ejaculation, that it's not for the purpose of having kids. And there's also another unique aspect to that the Orthodox Jewish couple cannot have intimate relationship while the female partner is on her period. And in fact, up until 7 days after the last day of a period, they're not allowed to even touch each other. So that makes it more challenging for them to conceive, because some women have short cycles and they basically would not be able to conceive if they follow just the religious aspect. So that was one aspect, but I think that, PUA, as one of the organizations that had reached out to me, has been partnering with Northwell Health Fertility for many, many years. Because, we're very welcoming to all types of, ethnicities and backgrounds and religious beliefs, but also because in Long Island there's a lot of Jewish community, and in Manhattan and in Brooklyn. So given that we're located in 6 different offices around New York City and Long Island, it was just a natural to come together and try to do the first event that of that sort that looks at the patient's perspective, the religious perspective, and us contributing from the medical perspective. How does it make it more challenging or less challenging when an Orthodox couple would like to conceive? They also have a unique aspect that we don't see in non-religious couples, that they are not intimate before their wedding, and they don't talk about sexual relationship as freely as you would imagine. And after the first night of the wedding, that's the first time they're becoming intimate. And some of them get pregnant that night, and believe it or not, because that's the first time that a female partner is exposed to a sperm. And it brings some, unique aspects and stress and anxiety, both on the male and the female partner. And I think that having a reproductive endocrinologist, having a gynecologist alongside with a rabbi, helps them kind of delve into that. Many of those couples will end up having more children than the average couple in the U.S. The average number of kids in the U.S. is somewhere between 2 and 3, depending on which state. In the Orthodox community, we're talking about well above 3 and 4 per family, which makes it a very important part of their life. So if they're infertile, that can have an impact on them, on their family members that are trying to get married and have their family. So I thought that breaking barriers, talking very openly with the community. We had over 150 members of that specific synagogue come, and it was, standing room only, as you remember.
Yes.
It's pretty impressive.
Beautiful turnout. So insightful. So tell us how this joint venture with PUA will allow for halachic standards.
So first, whenever we do an egg retrieval for an IVF or even an IUI, and I've done both today on many patients, the rabbis are essentially using PUA and other organization to assign something called mashgiach or mashgicha, which is a female volunteer who comes to our IVF lab, dresses up, getting a hat and booties and mask and scrubs, and basically sits there pretty much the whole day just to make sure that the right sperm and the right egg, which we do obviously on every couple, is used when this embryo is being created for religious reasons. And there's different reasons why it's more important for the Jewish Orthodox, but the idea is that if you have a Jewish mom, the child will be Jewish. And if you using a donor egg, for example, or using a donor sperm, or using a surrogate, that complicates things, and you need to get essentially the approval from PUA or other organization to make sure that the child doesn't have to be converted later on if a different egg or different uterus was used. So that's what triggered that. From my perspective, it brings another layer of confidence to the patient. So they get the PUA representative in the lab. It's very transparent. They can see that everything is done the kosher way, no pun intended. And I feel more comfortable. The patient knows that we have, those representatives, and sometimes they'll bring a Bible and they'll pray during the process, which we as doctors also pray to get all the eggs, to get the good embryo, to get a positive pregnancy test. So, so that I think is a very natural matchmaking with the organization.
How do you help an Orthodox person who is working towards their ovulation window, but they need to adhere to certain standards? Do you have a special workup that you use?
Yeah. So initially what we do is really focus on education. A lot of those couples are very young. They could be in their 20s, sometimes even, late teens, and just talking about it freely, sometimes separately with their wife and with the husband. And I think as a male reproductive endocrinologist, I relate to the guys, and I can talk to them almost in a more senior manner, and they respect that. And sometimes the female partner will be embarrassed. I always bring my nurse practitioner or my medical assistant or my female nurse to kind of like talk about things. Or when we do a transvaginal ultrasound, always make sure that there's a female present, and we make the room as comfortable as possible, dark room, making it as non-intrusive or intimidating to the patient, because it's a unique situation for that patient to come to a doctor and to talk about the reproductive organs. And the second thing that we do after the education is to talk about what is needed in order to have a baby. And you'll be surprised, sometimes those basic things are not taught in their, when they're teenager or kids. And we talk about the sperm, the importance of sperm, and 35% of the infertility is just a male factor infertility. And if you combine the male and the female, that can affect up to 50% of couples. So a lot of the times, the female partner is to blame, so to speak, even in her mind, that she's maybe not ovulating on time or she's doing something wrong. And the fact of the matter is that a simple semen analysis can reveal a lot of issues that can be corrected on the male part. And when they're not interested in doing a semen analysis as the first step, which is what we usually do in a non-religious couple, I communicate with the rabbi, get the approval, explain that, I've done the full workup on the female and everything came back normal. The ovarian reserve is good, the uterus looks good, the fallopian tube, the genetics are fine. And then we'll get an approval to do a semen analysis, and we'll use a special condoms, which doesn't have spermicide in it, and we can essentially analyze it under the microscope. The couple can have sexual relationship with that specific condom, bring it in a cup, and get with the approval of the rabbi, and then we can analyze it instead of just a guy comes into a sperm collection room, which we have at Northwell, and essentially watch a couple of videos and produce a sample. The other thing that we sometimes do, and it used to be very common in the 80s and the 90s, it's something called post-coital test. So I instruct the couples when the patient is 7 days from her last day of her period to have sexual relationship and to come first thing in the morning to see me. And then just like when we do a pap smear or cervical cultures, I'll place a speculum, swap some of the sperm and put it under a slide. That's a test that tells me that there's some sperm that's swimming. Because if I don't see any sperm, I know that we're talking about a much more complicated situation. And even just to know that they had sexual intercourse and that the guy was able to ejaculate and produce sperm in the vaginal vault, you'll be surprised. Sometimes, that's not even done. So that reveals a lot of the issues, whether or not there's an erectile dysfunction, pelvic pain, vulvodynia, endometriosis. Maybe they're stopping before, their climax and we don't even have a chance of conceiving. And you'll be surprised. There are really, once we get to that point of talking about it, you'll be able to resolve without any aggressive treatment or any proactive approach, just education and checking those things up front, and you'll be able to achieve a pregnancy pretty quickly. I think that once we get to the point that we know they're having unprotected intercourse, that the patient knows how to monitor ovulation, which is tricky, like you said. There's ovulation prediction kits, there are urine strips, there's a blood test, there's an ultrasound. So we start in a stepwise approach, advise them to go to a pharmacy, buy ovulation prediction kits, and roughly around the time that they go to mikveh, which is the cleansing pool next to most synagogues, to start checking ovulation. And once the patient sees a positive surge, that's when they need to be intimate. And sometimes they're intimate only once during the month. And guess what? It's 5 or 6 days before the egg drops or the patient ovulates, so you're missing the window. So advising that you should have intercourse more than just once and wait for that smiley face, which works in about 80-85% of those patients, just is a revelation for them. Oh, we didn't know. We thought it's only one time and that's it, and we wait to see if we're pregnant. So I think that for me, it encompasses a lot of of what I like to do in reproductive medicine. Educate my patient, be a partner with them, see what they're anxious about, what are the things that they may not even be aware that could be easily fixed. Taking prenatal vitamins, not taking hot showers for the guys, not smoking, not drinking alcohol, every night, making sure that he was wearing a boxer briefs and not tight underwear, not doing any medication that could affect the sperm, or not taking anything that is not going to help us achieve a pregnancy. So just that discussion in about 45 minutes or 60 minutes, you get so much information, and usually what the issue is. Is it that they're not having sex? Is it that she's not ovulating? Does she have PCOS, fibroid, endometriosis, or do we just need to change some lifestyle, habits and help them achieve that pregnancy?
Why has egg freezing now become such a common procedure and not a stigma anymore? You hear about it all the time. There's these egg freezing parties, webinars, workshops. Why is that?
First of all, I think technology have gotten to the point that we really can look at every patient that comes through the door and say, we can freeze eggs and we can make them sit in a liquid nitrogen for a year or 5 or 10 and get the same outcome that you would have if you came 10 years later and did an IVF retrieval multiple times at age, 35 or 40. So that's one. The technology was not there just 15, 20 years ago. So that's one. Social media helped a lot. A lot of the celebrities that came out, they opened and said, I wish I froze my eggs, or I froze my eggs at 30 and now I'm 45 and having a child with my own genetics. The coverage of insurance companies has dramatically changed.
Yes.
You know, we work at Northwell Health Fertility, and I remember when we started the Reproductive Endocrinology Division at Lenox Hill in 2012. You know, I came out of Cornell, and I had to sit with usually young girls and their moms. Sometimes they would come, or a friend, and go over how we don't really know if egg freezing is ever going to work, and we would sign a consent, something called IRB, Institutional Review Board would approve it, and the patient would do it because, you know, that was the only hope. The other alternative was to choose a donor sperm, which is 37 or 38 and not ready to give up the hope of having a partner, and freeze embryos, which we've been doing since the 80s, or alternatively just push the sperm in and do an IUI and try to have a baby and become a single mom by choice, which are very good and valid option, but may not be for everyone. So I think that the combination of the technology, the social media, the awareness that became really a very important part, and people talking about it and speaking freely about it, it made egg freezing an empowering tool rather than a point of shame. 35, just broke up with my boyfriend after 3 years, and now I'm going to a reproductive endocrinologist to freeze egg. It's the opposite. I have a lot of couples that are starting to date together, and the partner is sitting there and say, well, I don't know if this is Mr. Right or Mr. Maybe, but I'm freezing eggs. I'm taking, ownership and controlling my destiny. And I think that financially, that's the number one reason why many more women are not doing it. If you look at the SART, which is the statistics that the CDC is keeping, and about 400,000 women go through an egg retrieval a year. And the one portion that is rapidly increasing, as you said, is egg freezing and embryo freezing, meaning we're not trying to get pregnant right here, right now, but we're planning for the future, planning for baby number 2 or planning for baby number 1 that's going to come in 2 or 3 years because I want to do my PhD or my MBA. I want to be a consultant in this company or really focus on my career when I'm in my late 20s, early 30s, which is the best time to have a baby. So, the career and the reproductive age are in conflict in many ways.
Yes.
And by freezing eggs, you're achieving the best of all worlds. You're getting healthy eggs. You're keeping the option of having a large family if you want more than one kid. And you're making sure that you're reducing the risk of miscarriages. And guess what? When you have healthy eggs in your 20s or early 30s even, you can have a reduction in twins and triplets pregnancy. I just delivered a patient of mine after 4 years of infertility. She came and she froze eggs time after time and finally got to a sweet spot of about 24 eggs.
Wow.
And guess what? I said, let's keep it for baby number 2. And we did a simple IUI. It took about 5 or 6 cycles, and she ended up with twin girls just 2 weeks ago. So it's good and it's reassuring, and it provides some, maybe, stress-free, or maybe some reassurance that even if sex is not going to work or IUI is not going to work, I have my frozen eggs that I've focused on in my 20s or even early 30s, and I have some backup of reproductive insurance.
So I know you touched upon it lightly, but what is the optimal age for egg freezing?
So, when egg freezing started, and it became a non-experimental treatment back in October 2012 when the American Society of Reproductive Medicine released a practice bulletin that said, hey, you have to offer it routinely to every oncological patient, but also you can offer it now for social reason. And at that point, I remember women were usually in their early 40s. They were in academia. They were aware of egg freezing, or they're really in a good socioeconomic stage that they could afford $5,000, $10,000, $15,000 a cycle. So that was back in 2011, 12, 13. In the past decade, the age has dropped significantly. So now we're freezing eggs at age 25, 28, 30. And what we've learned from the ability of freezing eggs at a younger age, and some of it because they had coverage through their insurance, and say, why not? Is that those eggs survive in a much better rate and give us a much healthier embryo. Another thing that happened is, and I'm a big proponent of egg donation and surrogacy, whether it's for same-sex men or whether it's for single mom by choice that are at an older age or whether they failed IVF, is that we created egg banks. And what we learned is if we freeze a donor egg at age 21 versus 32, you get a different outcome.
Yes.
So now we have thousands of cases, tens of thousands of cases of women that froze in their early 20s to help other couples have a child. And we freeze 6 eggs, and we get 6 eggs that are surviving in it, 6 eggs that fertilize with the sperm, and you make 2 or 3 embryos. Whereas when you freeze 6 eggs at age 40, you'll be lucky if you get 1 embryo out of that. So you're essentially freezing eggs in order to become almost like your own potential egg donor if in 10 or 15 years you haven't been successful or you haven't found Mr. Right and you want to try and conceive. So if you want to freeze eggs, you want to be the younger that you can be. And that way you don't have to go through multiple rounds of a retrieval. It's going to be cheaper. You're going to take less hormones, and it's going to be much more successful when you come to use their eggs, if you come to use your eggs.
It's all around a better deal.
Exactly right.
Right? Can you quantify what percentage of eggs that will be frozen, thaw, and then survive? How many of those eggs will fertilize just as the fresh ones? And I know going back 14 years when I first did this, the stats were like 40%, but what is it nowadays?
Correct. So the good news is that when you're younger than 35 and you freeze eggs, over 90% of the eggs are going to survive the freezing and the thawing. I recently looked at it at Northwell Health, and we had about 92 to 93% survival rate in those young population, which is amazing. And when you get older, or if you have other comorbidities, say endometriosis or PCOS or some other issues, elevated FSH, and you're getting less eggs each time, and you're kind of like collecting eggs, usually we're talking about 80 to 85% of the eggs that will survive. Now, an important part of the survival is really that there's been good studies coming in 2010, 11, and 12 from Italy, from Spain, and from the US that showed that when we compared frozen eggs, autologous eggs, meaning women who froze their own eggs, compared to fresh eggs, and a lot of the women did one cycle of egg freezing and then chose sperm in the next cycle with the donor sperm to have both arms, some embryos and some eggs, we had very similar fertilization rates. So on average, we're talking about 50 to 70%, depending on the egg quality, but a good rule of thumb is 2/3 of the eggs will fertilize. Now, that's only one step, right? So we talk about freezing eggs, thawing the eggs, fertilizing the eggs, and then the next step is growing those embryos in our lab for 5, 6, or 7 days until they reach the blastocyst phase, which is the phase that we usually will transfer it back to the uterus. That is depending on the sperm, depending on the egg quality. So after the 50 to 70% fertilization, or an average 60%, about 20 to 40% will make it to the finish line. And at that point, a lot of the patient will choose to analyze the embryos, which is a big advantage of egg freezing as well. And you asked why egg freezing has been rapidly on the incline, also because genetic testing has been evolving, you know, and then in 2004, if I recall correctly, the Human Genome Project was completed, and we know that we have 30,000 genes, and every couple that are now trying to conceive and go to their OBGYN, they'll run a panel of 400, 600, 800 genes even to see if they're a good match or if they're overlapping with any genes that can cause deafness or kidney disease or cystic fibrosis or sickle cell or thalassemia or what have you. And we now do those tests, and some of those couples will be a carrier or BRCA gene that can put a patient at risk for breast cancer, or other genes that can put patient cancer. You can now eliminate those genes from the family tree. And how do you do it? You have to freeze eggs, or you have to retrieve eggs, create embryos in the lab, and then do a biopsy of what becomes the future placenta, analyze that embryo, and 2 or 3 weeks later, you know that this embryo is unaffected and is going to yield a healthy pregnancy. I've called 7 patients today with BRCA negative embryos, and they were crying. I mean, this is a patient who had an aunt, a grandmother, and mom who were diagnosed with breast cancer, and finally she can essentially look at her daughter, the future daughter, and say, you know what, I've taken that extra step, I froze embryos, I've analyzed the BRCA. We're keeping the BRCA positive embryos in the freezer because there may be gene therapy, just like we have now with sickle cell. But in the meantime, use the embryos that are unaffected to reduce the burden on the offspring in the future.
So what can be done to improve egg quality? I get this question all the time.
So I think it's a multi variable approach here. You have to talk about the holistic approach. You have to talk about acupuncture. You have to talk about nutrition. You have to talk about, you know, even state of mind. Because I see a lot of patients that go through a cycle after cycle, and you'll get variable results. It's not just the medication, and it's not just, you know, the length of the cycle or that specific, you know, IVF lab. I think a lot of it is what the patient is bringing to the table. So if you have a patient who is smoking or not eating healthy or not taking her vitamins, have vitamin D deficiency, and essentially coming into this process not in the best shape that she can be, you'll get not great eggs. The eggs in many ways are the reflection of the health, right? And when you take it to the extreme, if you think about it, women who are very, very thin, for example, who exercise 7 times a day and are athletes and so forth, they sometimes don't even ovulate. So the body knows that when your BMI is 17 or 18, which is very low, normal is 20 to 25, your body is not capable of carrying another human being in a way, right? So it protects you from that by preventing you from ovulating so you don't accidentally get pregnant when the body is not in the best shape to support the embryo and the placenta and the blood supply and so forth. So that's the extreme. But the vast majority of patients do ovulate. And the vast majority of patients are in the right range of weight, whether it's BMI 20 to 35, let's say, or mildly obese. So that should not have a significant impact. But nutrition is important, and making sure that you're not taking medications that are not safe in pregnancy. A lot of women take medication for different reasons, and they're not using protection. And when we get to the point of testing the embryo, we find out that there's issues that could have been prevented should that would, if the patient would have been made aware that this medication can cause fetal anomalies or can cause a miscarriage. And there's a slew of medication, and I know there's a black box on almost every medication, but women don't know that they can get pregnant fairly easily in their 20s.
Yeah.
And, if you don't use condoms or IUD or birth control pills more in a religious way, you may get pregnant and have pregnancy loss. And that also tells you that the health of the patient that goes through the IVF or the egg freezing should be optimized before you go through this route, because a lot of women, once they made a decision, they want to go through this immediately. I want to get the eggs before Christmas. I want to get, I just broke up with a boyfriend and I really want to get the 20 eggs. And sometimes it's not the best decision. So I think that an honest discussion, does it really matter if we'll do it in 6 weeks? Let's try and get rid of this medication, GLP-1s, other medication that are very prominent now, and get you safe through this process, and you'll have a better outcome.
Do you recommend supplements to your patients?
I do. So even if a patient is not trying to conceive, I usually test for basic hormonal panel. I check the TSH, the prolactin, their vitamin D levels, their CBC. It can tell us a lot if they're anemic, if they are missing iron. So that will be the first kind of like initial consult. And if they need vitamin B12 because of anemia, or iron or vitamin D because we're exposed to all this fluorescent light rather than sunny Australia or Miami, then we'll start with that. And then sometimes we'll talk about nutrition. Patient could be struggling with infertility because of PCOS, or have the PCO stigmata, which can present with excess hair on the body, or acne, or obesity, and other issues that go hand in hand. So that will be the first thing. And sometimes the patient is under a lot of stress because she belongs to a community that expects her to be pregnant at that point, or she has 2 sisters that already have 2 kids and she's the last one to try. So you need to also tackle that, because a lot of stress means sometimes taking a lot of medication to deal with the stress. And then you come into this process not really mentally prepared, and sometimes it's going to be even more painful and not a pleasant experience. And when you prepare the patient and set expectation, it may be a journey. You're not going to get 30 eggs in one shot. You're not going to get necessarily 20 eggs in one retrieval. I think you'll get better outcome. And sometimes they're surprised, but they'll say, let's take a month or 2 break. Let's reconvene. We just did a cycle in January. Let's meet again in March or in April. There's no rush. Whether you're 32 or 32 in 6 months, or whether you're 35 or 36, there's not a big gap. And as much as we want to get everything done and once and done and put it behind us, sometimes it's not giving us the best outcome. So I think that an honest discussion with the patient is critical here.
You've mentioned egg freezing technology, or vitrification, is getting better and better. Do you think that young women will use this as a common procedure?
I have no doubt. I have two girls. I also have 2 boys, but there's no doubt in my mind that my teenage girls, when they're, out of college, they'll be freezing eggs. I mean, the pendulum has shifted already from, as I said, early 40s, late 30s into early 30s and late 20s. I would say that women that are going to be covered for egg freezing, they'll do it probably right out of college. It will be almost like a routine and a standard approach. There's no doubt in my mind that that's coming down the pipeline.
It's amazing. And with the advancement of medicine and technology, it's like you're breaking the biological clock each and every day. Amazing.
Correct.
What is the cost of freezing eggs and the procedures associated with it?
So there's four aspects to egg freezing that makes it a little bit more expensive. So there's the medication aspect, and sometimes the medication will be covered because even if you don't have a partner or you're doing it for social reason, your insurance covers infertility. So it's the same medication that you would have used if you had a partner and were not successful. So that's the medication, and it can range anywhere between $2,000 to sometimes $6,000 or $7,000 per cycle. So that's really a very expensive aspect. And there's some push now with EMD Serono and Trump RX to try to lower the cost, which is we're all for it. It makes it much more cost effective, and some patients are not freezing eggs because of that aspect alone. The second aspect is the actual process. So it requires about 2 weeks of commitment, and there's about 4 or 5, sometimes 6 visits to the OB/GYN, to the reproductive endocrinologist, which is a quick visit, about 10-15 minutes, but that includes a pelvic ultrasound and a blood test. So those two have a cost associated with them. So the whole process usually ranges anywhere between, the cheapest I've seen is probably about $5,000, and the most expensive I've seen is probably about $15,000. So there's a range between those two numbers depending on which state, which center, is it an academic center, is it a private setting, and so forth. So that's the second and the biggest, I think, portion of the egg freezing process. The third one is the anesthesia. So we don't do it when the patient is awake. We give, a little bit of propofol. So the anesthesiologist is our partner. So today I did 8 of the cases I've done this morning were egg freezing cases. So the anesthesiologist comes and spends about 30 minutes with the patient. So it ranges between $500 and $750, and that's only if the patient is paying out of pocket, because a lot of the insurance companies, for example, Northwell Direct, which is the Northwell insurance for the 100,000 employees, is covering up to 6 cycles of egg freezing, or $45,000 per lifetime. And the fourth one is the storage. So that ranges anywhere between $500 to about $1,000 or $1,200 per year. Depends on the number of eggs, the number of retrievals, and so forth. A lot of the centers basically have one flat fee, but some will charge for the first 2, and then any additional cycles will be cost, and some charge per eggs if you have over 20 eggs, or if it's stored in 2 different locations. So if you combine those 4 expenses, the medication, the anesthesia, the procedure, and the storage, it can become an expensive journey. It can be anywhere between 10 at the cheapest to about 15 or 18 if you include everything included in that cycle. We do offer multi-cycle discount plans. If a patient is planning on doing 2 or 3 cycles, they can essentially get a discount on the second or third round, and you only pay one-time storage, for example, at this point in time at Northwell, which may change in the future. But we're trying to make it a much more, affordable, because we feel like you're going to have healthier pregnancy, you're going to have a satisfied patient. That patient is going to come back and use those eggs and have a baby and deliver, with us at Northwell in one of our 23, hospitals in New York, or the 7 hospitals in Connecticut. And I think that will help us get a healthier, pregnancy, singleton, which means 1 baby at a time, higher rate of vaginal delivery rather than a C-section. And I think that the grand scheme of things, it's almost like a vaccination, right? And if you freeze eggs, you're vaccinating yourself from having infertility in many ways, because a lot of the reason we have infertility in the Western world is delaying pregnancy, delaying conception.
Exactly.
The average age of first child in the U.S. went up since 1982, now 2025, from roughly about 23 to about 28. Think about that. Sounds only 5 years different, but when you come to have baby number 3 or 4, that's going to get you well into your late 30s, early 40s, which makes it very, very challenging to achieve. And that's without talking about miscarriages and fibroids and endometriosis and PCOS and male factor and tubal factor and gonorrhea and chlamydia and multiple things that can be in the way of achieving even the first pregnancy.
If a woman goes to see her gynecologist, do you think that this subject should be brought up? What's your take?
No question at all. I actually give lectures all around the world, and one of the slides that I like the most is called, and I came up with that term, the age visit, AGE. So, as you know, women used to go every year to have a pap smear, and that changed a few years back. And the American College of OB/GYN, essentially, and the American Medical Association said that, if your HPV is negative, or if you got vaccinated, or you're in a monogamous relationship, you can space those visits to the OB/GYN every 3 years. So what that did, and sometimes that was the only doctor that the patient have been seeing. We know that women see doctors much more than men, right? And they went because of the HPV, because of the pass-through, because of the breast exam. So now you're spacing it for every 3 years. So if you have a 30-year-old who has a boyfriend who's thinking, okay, he's going to propose and I'm going to get married and get pregnant in a year from now, next time that she sees the OB/GYN is 33. And if you haven't checked the ovarian reserve testing at 30 and found that there is a problem at 33, you're dealing with much worse problem. So that's one. So that stands for the A in the age visit, right? So AMH, anti-Mullerian hormone. Age and AMH. The second thing is G. G is genetics. We now have a simple blood test or a buccal swab that can tell you, you know what? You have balanced translocation, or you have karyotype that's a little bit abnormal, that you have a couple of genes that you're a carrier for, you're a carrier for fragile X that could put you at increased risk for early menopause. A simple blood test that you can basically educate your patient and advise her to take action if she wants to take action. Same thing with cancer gene screening. You take a careful history as an OB/GYN about ovarian cancer, breast cancer, different type of cancer in the family, prostate cancer, and you know that something sits there, you know, you're uneasy about the history that you just heard. Something is genetic there. And if you're on a panel of 30 or 40 genes that are responsible for cancer, you may tell a patient who's 35 or 38, you are at significantly increased risk for breast cancer. If you have BRCA, you may have up to 87% risk of breast cancer. Let's talk about what the next 2 years or 5 years or 20 years are going to look like. We may have to undergo mastectomy prophylactically so you don't end up having a breast cancer. You may want to remove your fallopian tubes because those are sometimes the cause of ovarian cancer. It starts in the fallopian tube. And you may want to take the ovaries out when you're 45 and not wait to age 50 or 51, which is the average age of menopause. So a simple blood test just changed that patient and gave her much more chances of making it through her 80s or 90s and making decision. And the last one in that age visit that I call it is E, and that's eggs or embryo freezing. If you're single, if you are not interested in incorporating sperm into the eggs, then you're freezing eggs. But if you're in a same-sex relationship and you're a lesbian couple, or if you know that you're going to be a single mom by choice, so you can choose donor sperm and freeze embryos. So eggs versus embryos, freezing should be brought up in every discussion. And a simple question asking, do you want to have kids? That's the first question. And what is the ideal family in your mind? 2, 3 kids, not having any kids. Some patients don't want to have kids, so that's a moot point, but you've asked it. Do you know about egg freezing? Here's a brochure. There's a couple of centers that offer it. Just go talk to the reproductive endocrinologist. That's covered by 90% of the insurances in the U.S. And I think that that's really important. That visit could really make or break. And I hear more and more women that are saying, you know what, no one talked to me about it. That should have brought up in high school, in college. I didn't know that that's even an option. And like you said before, about 15 years ago, slow freeze technique was very different. So women spent a fortune and they were pioneers and knew about it, and they froze 10 or 15 or 20 eggs. That's what they were able to afford, and only 40% survived. So that gave a bad stigma to the whole process of egg freezing. But now when we're going back to the survival being 85 to 90%, depending on the age, and the fact that we have data of live birth, and the fact that we have vitrification, which is the fast freeze, which is the right way to freeze eggs, changed everything. So to me, it's really a no-brainer.
Empowering them with choices is the best option, and choice is one of the most strongest options that we can have in our whole entire life, no doubt.
Right.
How has AI technology impacted your business?
In many ways, in fact. So I think that first, when a patient sits in front of me, she's much more educated of what I'm going to say, right? So you need to be a little bit more prepared, right? Just like 5 years ago, I would say, okay, this is your AMH, this is your FSH, this is what we see on ultrasound. I think you have about 30% chance of having a baby. So it's not uncommon for the patient to say, well, I ran my AMH, I sent it through this kit online, and I know that I have, AMH of 3.5 and I'm 32, and I know that my statistics is so and so. What is your statistics in your specific centers? And I think I need to have 2.5 retrieval sessions. So that makes my life in many ways much easier, because they can always validate what I say or ask appropriate question that I can essentially, address. So in the past, women thought they were sitting with a reproductive endocrinologist, they're 39, they have an AMH of 0.5, and it's a one and done. So when you say, well, unfortunately at age 39, you will need, 25, 30 eggs in order to achieve a decent chance of having a live birth, they can go to ChatGPT or one of those, AI and find out. So that's one. The The second thing, it helps us a lot in the IVF lab. So we can choose the best embryo to transfer, or we can have different features that are in our automated system, in our embryoscopes, that can tell me, you know what, you did get 12 eggs, but egg number 1, 6, and 8 are really no good. So let's not count those in and tell the patient that we have 12 eggs. We really have only 9 that look decent. So sometimes it's better than the naked eye of an embryologist, even though that embryologist may have 10 or 15 years of experience. And lastly, I would say in many ways it helps us accommodate more patients, because we have now a very high demand for egg freezing, and you don't want to overwhelm the lab. As I told you today, we had, a total of 21 retrievals in one day in both our IVF labs, and that's a burden for the nurses and for the staff and for the doctors and embryologists and andrologists. So AI tells me, you know what, when you have Emily, Sarah, Samantha, let's try and stagger them. One will start on a Sunday, one will start on a Monday, one will start on a Tuesday, and we can spread it a little bit more evenly, or we can, based on the number of eggs that we expect, decide how long the procedure is going to take, or which one of them we'll put first. Instead of just, trusting the experience of the doctor and the nurse or the clinical supervisor, you have another tool that tells you, hey, if you're doing today 21 retrievals, guess what? In 5, 6, and 7 days from now, you're going to have so and so number of embryos. So you should plan to have a backup and schedule. So AI really helped us in many, many ways to make it much more efficient, much more patient-friendly, be able to accommodate more patients and not to overwhelm the lab and the centers.
Should anyone in the fertility industry be concerned about their jobs being replaced?
I think that there's a lot of things that we can now do with AI. For example, just this past week, I've helped a same-sex male couple choose their surrogate, and I've gotten an application from Wichita, Kansas, and from Alabama, and from Utah. And instead of going through 300 pages of the surrogate's, OB history, there are 3 vaginal or C-section deliveries, AI can really scan through this and say, you know what, she had preeclampsia, she had diabetes, she's a no-go. Instead of spending now 3 or 4 hours going through the charts. That's one. So I think that, yes, a lot of the screening will be automated. It helps us in many ways with translation, right? So you have international patient that I see coming from the Middle East or from Europe or from South America or Asia, that there are some stuff that we can do in New York that are illegal. For example, egg freezing is not legal in every country when you're single, or doing genetic screening of embryos. For us, it's a second nature, but you cannot choose gender or screen the embryos in some countries. And I think that will also help. You don't need a lot of staff members that are going to be translating records and so forth. Another aspect is in the lab, really. And I think that, we now have an automated semen analysis machine. Something that took an hour and a half now takes about 85 seconds in automated semen analysis. So you need less staff to wash sperm for an IUI or to do a semen analysis. The ovarian reserve testing. When I was a fellow at Cornell, it took 3.5 hours for me to analyze AMH. Talking about, 2009. I'm showing my age here. Now, in 23 minutes, I put it in the machine and I get the results, and I say, you know what, well, by the time that I spoke to the patient about egg freezing, and I drew the blood before we went into my office, 23 minutes later, I can tell you, your AMH is, 3.5. We're in a good shape. See you in a year, or vice versa. AMH is pretty low. We need to get going and be more proactive. So a lot of those little things, will be improved, and I think that the demand is going to go up. So I don't think people need to be concerned about losing their jobs, but a lot of the things are going to be automated and maybe outsourced outside of New York City or in New York or the US into, other countries. But I think that overall patient care is going to determine, how important, the human interaction. I think that the difference between reproductive endocrinologists, whether it's in one academic center to one private center, is really the personal interaction with your medical assistant, your sonographer, your nurse, your physician, of course. I think that that's really key.
Yes.
Such an emotional process going into it. Miscarriages, infertility. I mean, the stigma of not having kids or having miscarriages, and a lot of the patient will blame themselves. I had a patient today who didn't get pregnant with a transfer, and she said, is it because I had 2 terminations? Is that why my uterus is not holding? And no, it has nothing to do with that. You know what? The embryo looked decent, the lining looked good, but it's still about 50 or 60% chance. And we have another 3 embryos in the freezer. And she said, should I look into adoption? And she really jumped from point A to point Z because of everything that she brought into that discussion or relationship before we even met. That's what she felt, that she's now in her late 30s, and because she had a couple of termination in her 20s in college because of that bad boyfriend, now she's not able to conceive. And, your job is to hold her hand and tell her it has nothing to do with that. I've looked at your uterus, I've done hysteroscopy, we looked, at the endometrial lining, your lining is nice and thick, we're going to get there. I think that that's important, and a reproductive endocrinologist should be honest with the patient when it's not feasible, we need to use a surrogate or adopt, or when we have a chance and we should pursue that aspect.
Any new projects in the pipeline?
What we really need to figure out is how to improve that one embryo that we have in the freezer to have the maximum chance of implanting, right? That's one. So a lot of research goes into that because we sometimes have 2 or 3 embryos, and it's easy because eventually the patient will take a baby home. But when you have only one embryo, how do we maximize? Do we do $1 million workup up front, or do we try the routine kind of like approach, and if it doesn't work, then do the workup? So that's one. We want to get to implantation rate greater than 70%, which is not exactly the case in most centers right now. So it's anywhere between 50 and 65 or so. The second thing is really, how do we know if the frozen eggs that we have a good chance of fertilizing? So AI will help, and embryoscopes and looking at different features of that egg. Right now, all I can tell a patient, I had a patient, believe it or not, this morning that I did a retrieval from Australia who got 64 eggs this morning.
Outrageous.
And she was, just
beautiful.
Yeah, but it also comes with risk, and she has PCOS, and I don't know how many of those. So a patient may leave the office and say, okay, I'm all set, and I don't know which one of those 64 eggs is going to create an embryo that's going to have chromosomal abnormalities. Mind you, she's set, she's never going to have a retrieval again. There's some risk that goes with that, ovarian hyperstimulation and others, but I would have liked to know that, okay, maybe I can get 20 eggs that are healthy instead of getting 60 eggs in that case, which is really the top 5% of the population, and essentially go through all those eggs and inject all those eggs with their husband's sperm and create embryos that all going to have to be tested. It's really a very inefficient process if you think about it, right? Yeah. And if you knew up front that egg number 3 and egg number 12 is the one that we want to focus on, it will save a lot of lab work that is unnecessary. We have a lot of supernumerary embryos that no one's going to claim. We have, at this point, over 1 million embryos, in freezers, just in academic centers that no one's going to claim, right? I'm not even talking about the vials of sperm that we have from donor sperm and partner sperm. So soon enough, we're not going to need men. We have enough in freezers. But it has advantages to some degree, if you ask my wife. But I think that this is where we need to focus, making the process more patient-friendly. Less monitoring, less coming into the office and, a hectic morning with 50 or 60 patients, and everyone is kind of like just dying to get to work and, is stressed about just being in that environment. Doing more monitoring at home, maybe home ultrasounds, saliva test, urine test that will tell me what the estrogen level instead of all the blood draw. So a lot of things that are coming down the pipeline that are going to make it much more feasible. You're going to have a telehealth, you're going to have a lot of testing at home, and then you're going to come to our IVF center, before the procedure and after the procedure for the egg retrieval and later on for the embryo transfer. And that even may change, the actual egg retrieval, which we now do transvaginally with a needle, that may change in the future as well. So I think that there's a lot of exciting things that are coming in reproductive medicine, and that's why I'm so excited and passionate about what we do.
So I like to ask my guests these rapid fire questions on fertility trends.
Sure.
Can you tell me if you could do the following while trying to get pregnant? GLP-1s.
You can, but you need to stop 2 to 3 months prior to trying to conceive.
Take magnesium.
No issues at all. It helps with concentration, with sleep.
Drink caffeine.
Usually I recommend 1 or 2 cups of coffee a day, not to overdo it, just for the sake of anxiety and pulse that's going to be rising if you take too much caffeine per day.
How about eating raw sushi?
Not when you're pregnant, just because usually you take a small risk of having a high dose of mercury, and also the kitchen could be dirty and have some other, infection that could affect the GI system. And you don't want to have severe diarrhea or food poisoning while you're really trying to conceive or already pregnant, especially in the first trimester.
Lifting weights.
My rule of thumb is up to 20 pounds is fine, or up to 20 blocks when you in the first trimester and after an embryo transfer. If you're spontaneously pregnant, the limit is much higher. So, but I usually try to limit because of the aspect of the pressure on the uterus, on the reproductive organs. Sometimes the patient did IVF and their ovaries are enlarged and the ovary can twist around its stalk. So being minded to the fact that things can, take the wrong turn is important. The patient is a little bit more conscientious. She's doing usually progesterone shots or vaginal progesterone, and there's some symptoms that I want the patient to report if they're, out of the realm of the normal symptoms. And when you're doing a lot of high impact physical activity or sexual activity, sometimes you'll have bleeding and you'll get concerned, or you have a subchorionic hematoma, and that will get the patient even more anxious. So I try to advise the patient, especially after an embryo transfer or in the first 6 weeks until we establish a fetal heart rate, to take it down a notch.
Going in the sauna.
Not good for guys and not good during the first trimester. The hot temperature is really not something that you want to expose the testicles to, because that has a significant impact on the sperm concentration. And in general, sauna is a place where you have a lot of, people that are using it, not always very sterile. So when you're pregnant, you're trying to protect, the uterus and the vagina from being exposed to chemicals and chloride and hot temperature.
Exactly. And the last one is cycle tracking apps.
So I actually got interviewed on that, and I think it comes with pros and cons. I think in many ways, when you have all those apps, it sometimes creates more stress and more anxiety. And I hear from the guys too that, they're dreading when their wife opens that app and she knows that, on Sunday between 6 and 8, that's where you predict it. So it takes away from the intimacy, from the spontaneity, and it puts a lot of pressure to the point that sometimes the guys won't be able to even perform. It becomes a chore rather than, and sometimes a day after the wedding, you get this ring and you get the 3 apps downloaded and you're on a mission. And I think it takes a little bit away from the spontaneity. On the other hand, for the patient that we discussed before, who don't really know when to have sex, or following mikvah, or, want to make sure that she's kind of maximize the event where she can actually conceive, it helps a lot, because some women, you'll be surprised, don't even know when exactly the egg is dropping and when they should be seeing, the cervical mucus or the temperature rise and so forth. So I like that we have that, but in moderation.
Good to know. Now, I like to ask all my guests, how are you prioritizing your mental health? You're a busy person, personally, professionally, and what are you doing for self-care nowadays?
So first, I have 4 kids, which are, love of my life, and my little one is 4 years of age, so that's the best part of my day. I make sure that I do the bath and the dinner with my little one. I like tennis. I like watching my kids play sport. We have a treadmill and we have a Peloton at home that when you watch kind of like the news or while listening to podcasts, you can exercise. And I have a dog, golden doodle, that I walk. So those are the things that I do, because I do have a very busy schedule. I start my day usually at 5:15. Usually it doesn't end until, 8 or 9 p.m. And usually the weekends is when I unwind.
And it's important to prioritize your needs and wants, especially since the outside world can be so stressful and it'll just keep piling on the stress. So good for you to take time out for yourself. Where can listeners get in touch, and what is your preferred social media?
So I like Instagram as my preferred social media. I also have an account on Facebook and Twitter. The Northwell Health website is going through a lot of improvement now, because we learned that that's a good way to communicate with our patient, and usually that's when you gather the initial information. And I think that, the best way to learn about the information that is pertinent to your issues is the American Society of Reproductive Medicine website. There's a lot of patient pamphlet there. The American College of OBGYN, which is really the organization that encompasses all the general OBGYN. There's a lot of good podcasts like yours that essentially help women delve into those questions that, and some of those AI will help you. You can put, I'm, 41, I have an AMH of 0.3. What does it mean? Because it really tracks, and it encompasses a lot of resources.
Well, Dr. Singer, I'll be sure to include all of this in the show notes. You are the best. Actually, when I started this podcast in person, as one of my goals, I put you on the list. So this is such a joy. And I can't thank you enough for carving time out to be with me today.
Thank you for having me, Melissa. It's been wonderful.
My pleasure.